Thanks to everyone who's joining us to hear Dr. Morley speak on the history of geriatric medicine. Dr. Morley's impact on the field of geriatrics is profound. So profound, I would consider it to be unmeasurable. His contributions nationally and internationally number over 1,500 scientific publications and tens of millions of dollars in grant funding. He's influenced the careers of over 150 geriatric medicine fellows at St. Louis University and hundreds, if not thousands, of clinicians, researchers, scientists, and others who have an interest and a passion for geriatric medicine. It's only fitting that we honor Dr. Morley's lifelong commitment to aging and to geriatric medicine by endowing him at the St. Louis University School of Medicine. Please see the QR code and the link for which you can indicate your interest in becoming involved in an endowment process in honor of Dr. John Morley. Please enjoy his presentation, The History of Geriatric Medicine.
So I would like to thank Dr. Julie Gamak for asking me to do this talk, and also congratulate Angela Sanford on becoming the Division Director for Geriatrics. My conflict of interest is VAI, which is a computer company that creates programs for older people, and all the rapid screens that you will see in this presentation are in the public domain. G.K. Chesterton said that history is the high point of advantage from which alone men can see the age in which they are living. We have to recognize that geriatricians are very happy people. This is a study done some years ago, but I don't think anything has changed, and geriatricians are way ahead of those in internal medicine. This is interesting because geriatricians are one of the lowest paid of the medical specialties, along with those in palliative care. Obviously, we should be thinking about how we can improve this and get better pay for geriatricians. There is a true shortage of geriatricians in the world. So let's look at what we're going to talk about, and perhaps the best way to think of this is with Ponce de Leon. Ponce de Leon went looking for a fountain of youth, and he came to St. Augustine in Florida and decided this was the fountain of youth. Unfortunately, when you go and swim in the fountain of youth, it does not make you younger. We have to look at the journey into aging. There are the blue zones around the world: Okinawa, Sardinia, Nicoya, Ikaria, and Loma Linda, where people live longer than in most places around the world. We have to recognize that when we look at these long-lived people, the reputation for longevity is based on hard work, a Spartan diet, regular exercise, regular fiber, little cholesterol, but most importantly, the inability to count directly. And at the bottom of this slide, you see the McDonald's at the entrance to Okinawa, and you also see two of the oldest people in the world who clearly are supposed to be 124 years of age, and most probably are not. One of the earliest thoughts about what the causes of death came from Weizmann, who speculated that death takes place because a worn-out tissue cannot forever renew itself, and because the capacity for increase by means of cell division is not everlasting but finite. There are a number of aging theories that have been accepted. Elie Metchnikoff thought in the beginning of the 1900s that bacterial toxins from the intestine may play a major role. And in this century, we have returned to understanding the importance of bacterial toxins in the function of the body. Paul Nierhans talked about cell therapy. And again, in this century, we're starting to begin to see that there may be ways to replace cells in older people. In 1935, Clive Mackay thought that dietary restriction in animals was a good way to do this, and further studies were done by Mazerow and Weindruck, and this remains a theory that is fairly well accepted to today. In 1957, Dennon and Harman suggested that free radicals damage tissue, and they may be an important cause of aging. In 1949, Anna Anselm basically decided that Geriatric or H3, procaine hydrochloride, most probably would make you live a long time. This was the first bit of aging that I ever came across because my parents both took Geriatric. It most probably didn't work, but she got enough money out of it to found the Institute of Geriatrics in Bucharest in 1952. When we look at the merchants of immortality, we have to recognize that there is a limit to cell growth. And Hayflick came up with this limit. It's when he sent it out to the Journal of Experimental Medicine, they rejected his paper, saying the largest factor have come from tissue culture research in the last 50 years is that cells inherently are capable of multiplying and will do so indefinitely if supplied with the right milieu in vitro. So, as is often the case, an esteemed journal got it totally wrong. In 1961, he published his Hayflick limit in experimental cell research, and others have gone on from there. In 1984, Carol Greider and Elizabeth Blackburn discovered telomerase, suggesting that that may play a role in the Hayflick limit. And in 1992, Geron was formed by Michael West, a company which was interested in trying to overcome the Hayflick limit. When we look at all the different ways in which cells get old, the senolytics, we realize that there are also ways to change this. So with DNA damage, we now recognize that resveratrol, metformin, and rapamycin may reverse this. MicroRNAs can both reverse oxidative damage and in some cases cause it. Clotho, when it's decreased, will cause senescence in the cells. Progerin may, in fact, prevent against free radical damage. Telomere damage is an important piece, and that has to be looked at. And there are a number of anti-apoptotic symptoms that exist. The immune system can obviously cause damage as well as being positive. Large numbers of lifestyle factors exist from exercise through to radiation that may be positive or negative for the older cell. The senescence-associated secretory prototypes exist to accelerate senescence, and this leads to frailty, sarcopenia, and cognitive dysfunction, as well as eventual death. Looking at things that might make a difference, Andy Wynn in our laboratory at SLU has been looking at progranulin, and he showed recently that progranulin is an excellent biomarker to pick up for frail people compared to non-frail. So what we know about progranulin is that it is elevated when inflammatory cytokines are elevated, and it appears to block the effects of the inflammatory cytokines. Sue Farr, also working at SLU, has shown that progranulin can enhance memory. So progranulin appears to be a potential senolytic in the future. More studies need to be done. We recognize that diabetes is often seen as an accelerated form of aging, and people with diabetes often get early cognitive dysfunction, but diabetes is not Alzheimer's disease. And it's important to recognize, though, that in animal models, metformin improves learning and memory in the SAMPA Alzheimer's mouse model, and biochemical analysis indicates the metformin improved memory by decreasing APP and phosphorylated tau. Metformin in humans has been shown in diabetics to decrease the memory dysfunction that you see in diabetics, and that's important. And in addition to that, in a long-term follow-up, metformin looked like it had about a 20% improvement in memory function in dementia in diabetes. Perhaps one of the most exciting things we've seen recently is the work by Jeffrey Scherer in our family practice program, working with a number of other physicians and researchers at SLU. What he has shown is that for both herpes zoster vaccination and Tdap vaccination, and more recently influenza vaccination, these vaccinations in veterans and civilians are associated with a reduction in new onset dementia. And very recently, a study came out doing a meta-analysis of adult vaccination protecting against dementia in a variety of studies. And what you can see here is that overall, there is a marked improvement in decreasing dementia to about 0.65 as the hazard ratio. So going to nearly 50% of the prevalence of dementia is reduced in people who have had a vaccination of some kind as an adult. BCG, which is a vaccine and is now used for many things, including bladder cancer. You can see in the study that BCG actually, people who got it had a much lesser dementia than people who didn't get it. Sufar and her colleagues have looked at Tdap in the SAMP8 mouse, and what Sue showed is that in these mice, if you give them Tdap by 12 months of age, when they're normally demented, you have totally prevented the development of dementia. Andy Wynn showed that basically this is most probably by decreasing inflammatory cytokines, and inflammation appears to be the way in which these vaccines decrease dementia. Gongpeng basically showed that FOX3 in CD4s and CD8s is decreased when you look at vaccinations. And these animals that we've looked at have been animals who have a prototype of Alzheimer's disease. And here we see that besides protecting against dementia, there are a number of studies that show that BCG vaccination now also protects against COVID-19. It seems to do this by protecting the T-cell immunity using both the measles, mumps, rubella vaccine and the Tdap vaccines. And this appears to be a very important way in which COVID-19 side effects can be reduced. Let's now turn back to the earlier history and look at human beings. And in the 13th century, Roger Bacon pointed out that if you had a controlled diet, proper rest, exercise, moderation in lifestyle, and good hygiene, you were more likely to live for a long period of time than if you basically didn't do these things. Being at that period of time, he also suggested inhaling the breath of a young virgin might make you live longer. There is no evidence for this, and it suggests much more that in the 13th century, men ruled the world and they thought that they were more important. George Edward Day, basically in the 1840s, came up with a textbook for older people and treating them. He said, "I offer no apology for the publication of this volume. The subject is one of the highest importance and yet has been strangely overlooked during the last half century by the physicians of all countries." When we published, I think, the 6th or 7th edition of Pathy, we said exactly the same thing. And in fact, today, it's still true that the average physician knows very little about aging. When we looked at Arnold Laurent in 1910 in his book, Old Age Deferred, he said when the sexual glands of a person are explorated, such as castrated people, be it a man or woman, soon they get old. He pointed out that we occasionally witness the peculiar fact that persons who live very moderately and eat very sparingly and who totally abstain from alcohol nevertheless become old before their time, while there are those addicted to the pleasures of a bounteous table and unstinted wine and spirit enjoy a green old age. He was making the point that I think we all know, that there's no single thing that decides what gets people old, but his point on decreasing testosterone in men has been held up in multiple studies. Here we look at the studies we did with New Mexico, where we show that with aging, there is a decrease in testosterone, and it goes down fairly dramatically with aging. This is also true of the free or bioavailable testosterone going down in men. Obviously, women go through a menopause. With Van Kaiser, we came up with a screen for low testosterone, which was the St. Louis University Adam questionnaire, which works very well to pick up people who are at risk of having low testosterone and need to be measured. And Ita C, when she was one of our fellows, showed that in older men who had low testosterone, if you replace the testosterone, you improved their grip strength to a reasonable amount. In the beginning of the 20th century, Nasher pointed out that geriatrics, from the term geros or old age and iatros relating to the physician, is a term that should be used as an addition to our vocabulary to cover the same field that is covered in old age that is covered by the term pediatrics in childhood, to emphasize the necessity of considering senility and its disease apart from maturity, and to assign it as a separate place in medicine. And this is where the term geriatrics came from. In the 1930s, Marjorie Warren in England at the West Middlesex Hospital pointed out that if you took older people who were in hospital, gave them an enhanced environment, introduced rehab, and emphasized increased motivation, you could actually improve their outcomes. Similar studies were done around the same time by Lionel Cousin in Essex in people with hip fracture, where he finished up saying, bed is bad or bed rest is bad. So what happened in the United States is we began to develop the National Institutes of Aging in 1940 with Edward J. Sticklow as the first head of the unit of aging, was in the division of chemotherapy at the National Institutes of Health. In 1941, Nathan Schock moved the program to Baltimore City Hospital, and in the same year, a National Advisory Committee on Gerontology was created. In 1948, the National Heart Institute developed the gerontology branch, and in 1959, James E. Barron was made head of the section of aging at the National Institute of Mental Health. And in 1974, on May the 31st, there was a Research on Aging Act, which began to change dramatically the approach to older people, particularly those in nursing homes and also at the NIA. The key players in the National Institutes of Aging were Robert Butler, Guralnick, and Ferrucci. All have made major contributions to geriatric science working at the NIA. In the key events in geriatrics in the United States, in 1966, Geriatric Medicine Fellowship was created for the first time at the City Hospital Center at Mount Sinai School of Medicine, with Les Lebo leading this effort. In 1967, he also developed the first teaching nursing home in New York. We pointed out that the National Institutes of Aging was developed completely in 1974. And most probably the major effect on aging through the 20th century was created by the Veterans Administration, who developed the first GREC, or Geriatric Research Education and Clinical Center, in 1976, and went on putting GRECs in multiple VAs. These basically did outstanding research, but also developed a number of treatment programs. We will show you the GEMU, which was first developed there. In 1977, we had the first professorship in geriatrics, and the following year, the VA became the supporters for geriatric fellowships throughout the country, which became an important part of creating geriatricians. And our first certifying exam in the United States was in 1988. I wrote that exam along with many other people. About half of the people who wrote that exam never went on to practice geriatrics. So that's why the numbers often are different when you say how many certified geriatricians there are and how many practicing geriatricians. The development of the different societies, this is the American Geriatric Society, was developed in 1942. The Gerontology Society of America was developed from the Club for Research and Aging in 1945. And AMDA, the Society for Post-Acute and Long-Term Care, was formed in 1978. All of these societies have their own journals and have become a major force in developing geriatrics in the United States. What have been the major geriatric topics in the United States? The first one was developed by Fries, which was the concept of compressing morbidity. What he said is that basically, if you did good care for older people, you would find that they lived longer, as with a healthy life, not necessarily living longer. And that was important and became the first major geriatric theory. In 1987, Rowe and Kahn suggested successful aging, which in their mind was that if you had the right genes, you would do very well and live a long period of time. I found this one a little unacceptable because obviously as a geriatrician, I had nothing to do with the genes at that time of what people were given when they were young, and so suggested that we really should be developing a theory of aging successfully here at St. Louis University, where the concept is that you can take people no matter what their genes are, no matter what's going wrong, but if you do good geriatric care, you will actually make them have a better life and live for a longer period of time. When we look at geriatrics, Bernard Isaacs came up with the giants of geriatrics, and his 4 giants of geriatrics are instability, immobility, intellectual impairment, and incontinence. Bernard Isaacs said geriatricians are certain they are specialists, but uncertain what they are specialists in. And today we have 10 eyes of geriatrics, the modern geriatric giants, which are instability or frailty, incontinence, intellectual impairment, iatrogenesis, incoherence or delirium, insulin resistance, diabetes, immobility, inanition, which is malnutrition, and impoverishment. The early development of geriatrics revolved around picking up ways to recognize people who had functional problems. So Sidney Katz came up with the activities of daily living in 1963. In 1969, Paul Lawton came up with the instrumental activities of daily living. A hybrid between these two was the Bartel index scoring form, developed at Johns Hopkins in 1965 by a physical therapist. And today, the major form that has been developed recently is the Japanese Ministry of Health, Labor, and Welfare, which is their Kihon Index, which was developed in 2008. So how did we start to change these problems that older people had? And most probably the first study that made this very clear that this could be done was the one done by Larry Rubenstein and his colleagues at the Sepulveda VA with Bob Kane also involved. And they developed a geriatric evaluation and management unit. and showed that if you put people who were in hospital directly into this unit and worked on improving their function, at 1 year, patients who'd been assigned to the geriatric unit had much lower mortality than controls and were less likely to have been initially discharged to a nursing home, and also that they had a better function. So that was the beginning of the GEMUs, which have been used widely throughout the VA and to a lesser extent throughout the community. Mark Beers at UCLA was interested in developing a way to decide which medicines were good, which medicines were bad, and how to get rid of the bad medicines. He developed the Mark Beers criteria. I sat on the second committee for this. I suggested that reserpine should not be on that criteria. And this is something that happens a lot when people create things. They think this drug is bad, but you always have to define whether the drug is bad or is bad and good, and whether it's bad and good is better than another drug, which is not very good and perhaps not bad. So I think it's important to recognize there are a number of flaws in the Beers criteria, but they have continued to be fairly successful and used. In Europe, the method used has been, to a large extent, the stop and start screening tool of older persons' prescriptions and screening tool to alert doctors to the right treatment. Very important, again, the concept of inappropriate pharmacotherapy and polypharmacy remains one of the major things where geriatricians make a major difference in older people. Ken Rockwood, working up at Dalhousie University in Nova Scotia, was very interested and has been looking at frailty for a long period of time. He, together with Arnold Laurent, developed the Frailty Index, which is really a comorbidity index. It just adds up how many things are wrong with you and says that if you've got a lot of things wrong with you, you are going to be frail. It doesn't really help much in deciding what to do about people, and I question whether it's a reasonable frailty index. Rockwood, who is an outstanding clinician, also developed the clinical frailty scale, which is actually a very good tool if you're a very good clinician, because the problem is that with most people, you're sort of very fit or sort of okay, and if you're terminally ill, you get a 2-point line going from one to the other. The people we care most about are the vulnerable and the mildly frail and the moderately frail, and those tend to get poorly diagnosed by most clinicians when you use the clinical frailty scale. Basically, I worked on a number of frailty scales, and in the second half of 2014, I was in Australia, and Renuka Viswanathan said to me, you know, Professor Morley, you've originated all these tools, but they don't work for people who are in residential facilities. And can you come up with something that will work? So on the way going from Adelaide, where Renuka works, to Melbourne, I sat down on a plane and I came up with what I called the Frail NH scale. And together with Kerr and Maelstrom, we actually showed that this scale was a good scale and could be very useful. There are now about 26 papers that have been published showing that the Frail NH scale will work, and it has been used at least as a guideline for people in New Zealand. So it's become their Health and Quality Safety Commission guideline, something that works fairly well. The Frail NH scale you see here, looking at a variety of different factors. And in the original study with Kerr, we showed that pre-frail people were more likely to be deceased or go to hospice in 6 months, and frail people even more likely. Excellent study was done in Hong Kong, looking at their version of the Frail NH scale, or what they call the Frail MDS, and using a cutoff of 4, they showed that basically people who were positive had a higher risk of mortality and also problems with ADLs. They also showed that frail residents were more likely to have incident falls, be hospitalized, and have, as we said, worsening of their ADLs. The first major definition of frail, looking at it from a physical point of view, was done by Linda Fried in Baltimore. And Linda basically said we should look at weight loss, 10 pounds in a year, exhaustion by self-report, weakness, grip strength in the lowest 20%, walking speed 15 feet that's lowest 20%, and low physical activity. And if you put this together, you would find that about 6.9% of the older population were physically frail, and females tended to be more likely to be physically frail than male. An excellent way to look at aging, but it takes a fair amount of time to do. Looking at it, and at a meeting in Barcelona, I was sitting listening to people talking about Rockwood's scale, and I thought, well, there has to be a simpler, easier way to do this, and so came up with the Frail scale, which was fatigue, resistance, climb 1 flight of stairs, aerobic, walk 1 block, illnesses more than 5 illnesses, loss of weight greater than 5% in 6 months. And if you were 1 or 2, you were pre-frail, and 3 or more, you were frail. This has now been validated. I say there 30 times, but in fact, it's over 50 times. It works very well to pick up people who have problems, and in our hands has been excellent in pointing out who we should treat and what we should aim at treating. Jean Wu, who's done incredible work in Hong Kong, compared the Frail scale in males and females from the different groups. So she looked at the Rockwood, the CHS scale, which was the Fried scale, our Frail scale, and another Canadian scale, the Hubbard scale. And you can see that all of them were very good at picking up people who were going to fundamentally have go on to die or have physical limitations there. While they were very specific, all have poor sensitivity. Sharon Inouye in the early 1990s started to look at delirium when she was at Yale, and came up with the confusion assessment methodology, which is an excellent way to pick up people in hospital who have delirium. And this has been well used. Out of this came the Hospital Elder Life program to help people with delirium, and also the Nurses Improving Care for Health System Elders, the niche program. Both of these used the CAM and then said, if we use the CAM and we go on and we improve care for older people in nursing homes, we can reduce delirium. In Scotland, Alistair McCullough came up with the 4AT screen. I always like to point out that the first basically falls screen that was well done was by Mary Tinetti. Mary was at the University of Minnesota. She then went on to Yale and developed the scale in 1986. When she was at the University of Minnesota, she came to talk to me and said that she thought she would become a geriatrician, and I told her she was foolish and stupid. I was an endocrinologist at that time, and that she really should come into endocrinology, and we would give her a fellowship and then put her on faculty straight away. She was an extremely bright young woman. She saw that I was stupid, and she went ahead and went into geriatrics instead. Landerfeld and Jerry Coe, originally in Cleveland and then in San Francisco, went ahead and developed the acute care for the elderly, which has turned out to be an excellent approach, putting older people in a place where nurses are trained, know what to do, and the physicians remember that these people are older and they need a somewhat different treatment. When we were doing this, Joe Flaherty was in our group, and we went ahead and said, what can we do for delirium? And we came up with the delirium intensive care unit, which has been highly successful, where it's been used both at SLU and De Pere Hospital in St. Louis, but also in Asia. So excellent approach is to take people with delirium, put them in an open unit where the nurses can watch them, give them positive support, no restraints. A big thing about life in geriatrics in the States is that people think that if you're upset and not nice, you should be tied down and that will be good for you. And all that does is it's extraordinarily harmful. And I find it very sad that there are still many nurses and physicians who think that physical restraints are something we should do. So let's go on from the frail to the sarcopenic. Irvin Rosenberg came up with the term sarcopenia, sarx for flesh, penia for loss of flesh. And basically, Richard Baumgartner in New Mexico developed the first studies in sarcopenia, and then came up with the approach to the concept of sarcopenic obesity, pointing out that obese people who didn't have muscle strength had an even worse outcome than either obese people or people who were sarcopenic, and that this was a high predictor of loss of instrumental activities of daily living and disability in the elderly. I was fortunate to be on the first paper with Rick when he put this out. It was a very important study that has been very well carried out. The best studies have been done by Duque in Melbourne in Australia at this stage. Alfonso Cruz Gentop, working with the European Working Group, came up with a definition saying that sarcopenia should involve both function and lean mass. And in the recent versions of the European Working Group, they have added SARC-F as a screen. And Bull Evans basically looked at different ways to measure sarcopenia and came up with the tritiated creatine dilution method, which is better than any of the others that we have available at the moment. This is the SARC-F screen for sarcopenia that we came up with. Strength, can you lift or carry 10 pounds? Do you need help in walking across a room? Can you rise from a chair without needing help? Can you climb a flight of 10 stairs? And how many times have you fallen in the last year? And if your score is 4 or higher, you're considered to have sarcopenia. And a study in Japan looking at this showed that people who were 4 or greater basically had worse grip strength, worse quadriceps strength, one leg standing, SPPB, usual gait speed, and 6-minute walking distance. So the SARC-F is an excellent way to pick up people who've got sarcopenia when you're in a hurry. This is a study that Ted Malmstrom did with us, and what we're showing you here is that people who were positive for SARC-F longitudinally had worse ADLs, worse IADLs, more likely to be hospitalized overnight, had a worse gait speed, and more likely were to die. It also had poor chair stands and grip strength. One of the things that is used as a key approach to treating people with sarcopenia and keeping people functional when they're in hospital is exercise. And Maria Fiataroni, who was my fellow when I was at UCLA before I moved to St. Louis, basically came to me and said, I want to do research. And I said, sure, Maria, and I've got lots of things you can do, and you should be very excited about this. And she sort of looked at me and said, well, the only things I'm prepared to work on are exercise, because I believe exercise is the way you fix older people. So after a long conversation, we were working with George Solomon at that time on natural killer cells. And so I said, you know, Maria, if you exercise, you most probably improve natural killer cells, and that's how you make frailty go away. And so she said, well, I don't really want to do this, but I'll do it. She did it, and she showed that exercise is a marked way, a great way to increase natural killer cells. Subsequently, she moved to Harvard. When she moved to Harvard, people were much nicer to her than I had been, and she basically showed that high-intensity progressive resistance training would markedly improve outcomes in people who basically had sarcopenia or frailty, and she did some excellent studies and then moved to Australia, where she's continued to do studies like that. Perhaps the single best studies done on exercise in hospital were done by Mikel Esquerdo, and what Mikel showed that in a hospital, exercise intervention stops functional decline and has people have much better discharge from hospital, and others have looked at people in the ICU and shown that early physical and occupational therapy in mechanically ventilated critically ill patients will also improve outcome, and that older people in the ICU should be got out of bed, even if that means maintaining their oxygenation and other therapies to get them to walk around. The next geriatric syndrome we cared about was anorexia of aging. Cicero had pointed out that he was grateful to old age because it had made him more interested in good food and less interested in exercise, so that he thought this was a good way to be. And fundamentally, he pointed out that he wasn't that hungry when he was old. So Andy Silva was one of my first fellows, was Maria Fiataroni in California, and eventually moved to St. Louis University with us. And we worked on, in animals, a number of things to look at the causes of anorexia in older people. And these seem to be mainly due to changes in the stomach, the way the stomach worked, with a decrease in adaptive relaxation. So anterostretch occurred earlier, and that led to an increase in cholecystokinin. There were other factors obviously involved in the decreased food intake that occurs in older people. Andy did the study on CCK with our colleagues in Australia, and we showed that anorexia of aging is important in older people. We then came up with David Thomas and Margaret Wilson with a simplified nutrition assessment questionnaire, where we pointed out that my appetite is very poor, very good. When I eat, I feel full after eating only a few mouthfuls or hardly ever. Food tastes very bad or very good, and normally I eat less than 1 full meal a day or more than 3 meals a day. And if you are less than 15, it predicts that you will have significant weight loss within 6 months. This is true whether you are young or old, and has become an important way to pick up the anorexia of aging. Bruno Vallas, when he was at the University of New Mexico, basically came up with a mini nutritional assessment, which is an excellent way to pick up early malnutrition in older people and to show people who are going to have bad output. Subsequently, Bruno has now become the chief in Toulouse at the Gerontopole, which does excellent research in aging. Pierre Michel there developed the European Academy for Medicine of Aging, which quite honestly was the most inspiring moment of my professional life as a geriatrician. I learned more at his meetings than at any of the other meetings. He used to invite me to go talk and I'd go to learn, so it was very good. The exercise programs that are widely used in Europe are the very Frail programs that were developed by Mikel Esquerdo together with Leo Ricardo Manas, and they are really excellent and worthwhile looking at. What about emergency medicine? Well, back in 1993, Art Sanders and I wrote a review paper on the older person in the emergency department, saying that we are not doing a good job with people in the emergency department, and Art went on to get emergency physicians involved and he published The Emergency Care of the Elder Person book. We're here in St. Louis, at St. Louis University, with Larry Lewis, Doug Miller. Basically, we did a controlled trial of geriatric case finding and liaison service in the emergency department, and showed that if we paid attention to people who had geriatric problems, they could do somewhat better. And we also pointed out that delirium was poorly picked up in the emergency department in geriatric patients. Since then, Chris Carpenter has gone on at Washington University, where Larry went to become the chief of the emergency department there, and has been a leader in developing the birth of emergency medicine geriatrics. Excellent work that they do there. What about nursing homes? The earliest nursing home was developed by St. Helena, the amateur Matthias nursing home in Constantinople. And these were originally considered as poor houses for old men and women in Amsterdam in 1650s. And it wasn't until basically we got into, most probably the 80s, where we started to see people paying real attention at developing good care nursing homes. Les Lebo, who you see in the middle there, developed the first teaching nursing home in 1967, and he went around the country telling people that this is important. Basically, in 1965, Medicare and Medicaid were created in the United States to help older people and to provide the cost for their care in hospital and nursing home. And the Institute of Medicine in '86 published a paper pointing out that we needed to improve the quality of care in nursing homes. And in 1987, the OBRA regulations came out saying that patients in nursing homes should have a standard assessment, restraint, psychotropic and Foley reduction, and comprehensive care planning, and there should be quality indicators. Nursing homes come in all types. There are social nursing homes, nurse-run nursing homes, and physician-run nursing homes, and these are different in different parts of the world. The resident assessment instruments are not used in all countries, only in about a third. Physician visits to nursing homes are variable, but can be as low as 37% in some countries, and all but 2 countries used advanced practice nurses when we looked at this. Basically, the MDS basically was developed by Brian Fries, and this in 1991, they started looking at it. The MDS 2.0 came out in 1995, and it's important to recognize in Europe and other parts of the world, it was changed slightly by Professor Roberto Bernardi and his colleagues, and it's now called the INTERAI internationally. And the MDS 3.0 was published in 2008, and that was done by Deborah Saliba, and it is really dramatically different from the MDS at the beginning. Is far better in my mind, and basically is really what should be done in nursing homes. So let's go on now to dementia. And we all know that dementia basically, or Alzheimer's dementia, was named after Alois Alzheimer. He had one whole patient. She was in her 50s, so she wasn't a true patient of Alzheimer's as we would think of her today. And he published on her, and basically he finished up getting the credit for naming the disease and had it named after him. In 1906, Solomon Carter Fuller basically was developing a series of, and published a series of Alzheimer's patients. Prior to him, in 1898, Emily Ruddock, and then in 1882, Paul Bloch had both shown that the plaques occur in people who have dementia. And in 1907, Oscar Fischer published a large series of people with senile dementia. So when we look at it, whatever, and I forgot to mention that Miyake in Japan also did this. So whatever the disease should be called, it should not be called Alzheimer's disease, but this is how history comes about. The concept then went on for people to say, look, Alzheimer's disease is due to an amyloid cascade being developed, and George and Joy Glenner said that Alzheimer's disease is amyloidosis in 1984, where they were looking at it in children with or adults with Down syndrome. John Hardy and Dennis Silko worked very hard on showing that the center to Alzheimer's disease was the development of amyloid precursor protein leading to amyloid, which produced an increase in GSK3, leading to phosphorylation of the tau and neurofibrillary tangles. It also led to the amyloid plaques, and it caused a decrease in memory because it lowered acetylcholine. And in addition, it damaged the mitochondria, leading to oxidative damage with increases in TNF and IL-6, which would then further increase the amyloid precursor protein. This became known as the Baptist theory, or the brain amyloid protein theory of Alzheimer's disease, and is still very popular today. As an aside, I want to say that most probably Alzheimer's disease is really predominantly a disease of inflammation of the brain. The amyloid plaques are mainly, most probably more protective than basically accelerating the Alzheimer's disease. And these are my opinions, not believed as far as I can work out by very many other people. The cholinergic hypothesis showing the decrease in acetylcholine was developed by David Bowen and Peter Whitehouse, and Peter Whitehouse said that Alzheimer's disease is more of a disease of minds than of brains. So work that we did with Jim Flood and then with Sue Farr showed that amyloid beta protein actually would improve memory when given in low doses. And this basically made sense, but what we noticed is that when you got to high doses, it actually made things worse. So the physiological role of amyloid beta protein is to improve memory, not to make it worse. And that's important to recognize. And we showed that basically when you did these low doses of beta amyloid, it actually would increase acetylcholine in the brain, and that fundamentally, if you used antisense to beta amyloid precursor protein, you could actually improve memory in people who had or animals who had Alzheimer's disease. Vascular dementia, the Heshinsky score was developed by Heshinsky in Canada, works very well to pick up people with vascular dementia, and obviously it is different from Alzheimer's disease, though like Alzheimer's disease, inflammatory disease seems to be an important component. Prion disease or spongiform encephalopathy was basically first recognized by Louis Body and Peck, and they basically created these concepts of these diseases. Gajusek brought back brains from Asia and looked at them and showed that they had these scroppy-like things in the brain, and he called this the Prion disease. And you can see there that the first sheep with Prion disease was seen in 1732. In 1920, Creutzfeldt and Jacob further pushed the concept, and Prusner in 1982 named the disease, saying it was due to prions. that were producing the problem. Then we have to look at the changes in measurement of memory. The first person to measure memory was Marshall Falstein in Cornell, along with his wife, Susan, who was a resident at the time. And she apparently presented a case to Marshall, and he told her in front of everybody that she was an idiot and didn't know what she was doing. And when he came home that night, she said to him, Marshall, let me tell you that if you ever do that again, I'm going to leave you. And if you don't teach me how to do a good mental status examination tonight, I'm going to leave you. This is how you got the mini mental status. The mini mental status is not as good as the SLUMS, the St. Louis University mental status exam. Is somewhat better, particularly when you're looking at people with mild cognitive impairment. And the same is true for the MOCA, the Montreal exam, and more recently, the rapid cognitive screen, which we've developed as a quick way to do this in the clinic. How do you treat people with cognitive dysfunction? Well, we all know that you can use cholinergic enhancers, but most probably more importantly, the working of Martin Arrow, Bob Woods, and Amy Spector at the University College of London came up with a cognitive stimulation therapy test, and these were the three major manuals now available. Excellent way for improving memory in people who have moderate to mild dementia. Studies we have done here, particularly the studies done in Perry County with Jane Lundy, have shown that CST will improve people's memory very well, and the same sort of things have been done with the team at A.T. Still University with our GWEP team there. Just point out that they also in Perry County showed that people with sarcopenia could have a marked improvement if you basically gave them exercise. And about half of the people in Perry County have been screened for dementia by the Perry County team. Other approaches to this are the football or soccer reminiscence interventions within long-term care, originally done by Debbie Tolson and her colleagues, and this has worked very well. We adapted this year to baseball, and Nina Tomosa did an excellent job showing that we could take people at the VA and improve their dementia by asking them to do memory things associated on a weekly basis with baseball. When Nina left, the program moved to the Alzheimer's Association locally. Other things that have become important are resilience. John Beard, when he was working at the World Health Organization, developed the ICOPE, which is an integrated care for older people to treat people who have poor resilience. There are 5 steps to the program: a screening, assessment, a plan, ensure the referral pathway, and monitoring, engaging communities and supporting caregivers. This program has been best developed by Professor Bruno Vallas and his colleagues in Toulouse, and they have shown excellent outcomes by using the program. The program uses a digital approach to making sure that it is done properly. The John Hartford Society, with help leadership of Terry Fulmer, has developed the 4Ms project, which is what matters to the person. Are there medication problems, something wrong with their meditation and mobility? And this is called an age-friendly approach that they have. And the rural aging, age-friendly society in Perry County uses the rapid geriatric assessment. They also use a team approach, which is a social worker, occupational therapist, physician, physical therapist, exercise therapist, dietitian, nurses, and right at the end, physicians. The patients get screened and they get sent to the physician when there is a thought that the physician might have to do something. But mostly these patients are put into programs that the Perry County has, which include the exercise programs and working with cognitive stimulation therapy. They have been very, very successful with that approach. Rishma Merchant, professor at the National University of Singapore, I went out there and we talked with them, and we both felt that telehealth with AI is going to be the future of geriatrics. And she took our rapid geriatric assessment and started to do it in a large number of people who were being seen at the National University of Singapore with excellent results using the iPad to do this. We have developed a computer assessment for the annual wellness exam. It includes the rapid geriatric assessment, but it also includes loneliness, basically the depression scale, ADLs, the Frail NH, the ADAM, and also we ask what matters. We have done very well at screening people to do this throughout Missouri, working with multiple different centers, and we have screened over 20,000 people at this stage. So it's highly successful for screening, and it leads people to what should be done for the person. So just to finish up, we point out that one of the first major textbooks was in geriatrics was done by Edmund Vincent Cowdery, who was at Washington University, and in 1958 he published The Care of the Geriatric Patient. The leading geriatric textbooks around the country are fundamentally Chris Castle's Geriatric Medicine, Brockelhertz's textbook of geriatric medicine and gerontology, Hazard's Geriatric Medicine and Gerontology, The Essentials of Clinical Geriatrics, which was put together originally by Itamar Abras, Joe Auslander, and Bob Kane, and is most probably the easiest and the most readable. It's a condensed version. And then Pathy's Principles and Practice of Geriatrics, which basically was taken over from Pathy by Alan Sinclair, Bruno Vallas, and myself, and now has a whole series of people editing it. So this at the end is saying where we are with our geriatric workforce enhancement program. We provide education and care in 6 congressional districts in Missouri. We have done educational programs in 42 states and 43 countries, and we've done 18 disciplines. The program was originally run together with me by Nina Tomosa, who's now running the GWEP programs at HRSA in Washington, and her position was taken over by Marla Bergweger, who is now since I retired in June, the director of our GWEP programs. So to conclude, Isaac Newton said, "If I have seen further, it is by standing on the shoulders of the giants." I hope this lecture gave you an opportunity to say there's lots of stuff out there, and can we move this in a way that it is used by all people in primary care medicine? And we have a long way to go to do this, but only when that happens will we start to see really major improvements in the care of elderly. Thank you all very much.